Okay, we are being recorded.
Fabulous, thank you. So good afternoon, everyone. Welcome to the House Bill 2002 Gender-Affirming Treatment Rulemaking Advisory Committee meeting. This is our third meeting, and I just want to begin. I'll start the meeting going over just a brief welcome and housekeeping items, and then we will, as a heads up to the RAC members that submitted written comment after the last RAC, we're going to invite you the opportunity to highlight anything that you would like to highlight from your public written comments, although they were posted on the Rules Advisory Committee website in early March. And so folks should have had the opportunity to review those, but I want to give you the opportunity during this first part of the agenda to make any comments that you'd like to make. So we're going to forego introductions because we've done RAC member and division staff introductions before, but just would ask that before you speak that you do introduce yourself again and your name and your affiliation. If you do raise your hand to speak, that is preferred if you'd raise your hand first so that we can be conscientious of who, the order of people that like to speak. In addition, if you're not speaking, if you could please keep your lines muted, that's appreciated. Feel free to be off camera or come on camera when you are, if you are going to speak. And just a reminder that only division staff and Rules Advisory Committee members can participate in the discussion during the main core of the agenda until we open it up for public comment. And if you are joining today and you would like to, you have submitted written comments as an interested party, or you would like to make an oral comment today, if you could just put that in the chat so that Karen and Brooke, who are tracking that, can kind of queue that up for when we get to the public comment time period, and also that we allow enough time to get to all of you. So we ask you to please do that for us. All right, let's go ahead and get started with reviewing the Rules Advisory Committee member written comments that were submitted. And I'm kind of going in alphabetical order, and just, again, you can take this opportunity or not, but I want to just at least acknowledge that written comments were submitted. So Seth Johnstone with Basic Rights Oregon, is there anything that you would like to highlight about your public comments or anything you would like to go over? You're welcome to do so.
Thank you. Seth Johnstone, Basic Rights Oregon, Transgender Justice Program Manager. Within my public comment, I recommended that there be some sort of a reviewer just metric in terms of the amount of experience we would expect that reviewer to have. Some of the recommendations I'd love to re-highlight, given the reading of the revised rule, were just the recommendation that there be training in WPATH, as it's our certified national standard of care here that we use. And it might be helpful to actually clarify that in the recommendation of training in the revised rule. In one of the lines under the reviewer protocol, it had listed GEI in small parentheses, but potentially making that a little bit more explicit, that folks shouldn't just have a 101 training from any source, but from a source that would be helpful in determining it meeting the protocol for this current standard of care we're using. So more clarity there would be great. And I think the other components of the reviewer guidelines were also to be practicing within there's a line number 2 about practicing within the scope of their license. And I think maybe it was mistranslated what we had recommended there around practicing within the scope of gender-affirming care or experience in gender-affirming care specifically. And so just wanted to clarify that comment that we had listed. I think there are a couple more components around WPATH being the main standard of care that is evidence-based, that includes studies over the last 10 years, that's led by the lead surgeons in this field. And we have some stuff we'd love to discuss later around the addition of adding in other standards of care that have not been vetted and were suggested in the other public comments. So looking forward to that discussion, and I'll turn it over to some colleagues.
Lisa, you're on mute.
Sorry about that. Thank you, Seth. Thank you, Brooke. And yeah, we're happy to have further discussion. I'm gonna perhaps, is Amy Penkin one of your colleagues, Seth?
Amy Pinkton works at a different organization. We are not coworkers.
Okay. Well, just for the essence of time, Amy, if you wouldn't mind holding your question and comment for now. We're just going over the RAC members' written comments, public comments that were submitted. And then when we go over the actual draft rule, we'll open it up for comments. And then, of course, just as a reminder that during this part of the discussion, comments are reserved to DFR staff and RAC members who are listed on the RAC website that I put in the chat. And then we certainly will open it up for public comment. And if you want to make a public comment during the public comment period, would you please put that in the chat so that we can track that and make sure we allow enough time. Thank you. So next, let's go to Cambia. Antoinette, if you would like to go over Cambia's written comments, or in detail, or highlight what you'd like to highlight. You have the floor.
Okay. Thank you. And we appreciate the opportunity to highlight what we provided in a write-in last month. But I should preface that we also provided comments on the DFR's draft bulletin, which had since been issued when we provided comments on the draft rules. And of course, with the bulletin, it's intended to provide interim guidance until the final rules implementing Section 20 of House Bill 2002 are adopted. We thank the DFR for accepting one of our recommendations, which was to revise the definition of accepted standards of care so that insurers can use other reliable and credible medical evidence sources as appropriate, and not only WPATH's version 8 standards. However, when we attended the January 25th RAC, it was clarified that the statements of recommendations are the only part of WPATH guidelines that are intended to be considered as standards of care. So we requested that the draft rules follow the bulletin's definition of accepted standards of care, but also add statements of recommendation. But we see that the revised rules that was provided to us last month does include the statements of recommendation. So thanks for that. But there were other parts of the bulletin that still remained unclear, in which we would like for the rules to be amended to reflect. And part of that was the denials of claims. We requested that the DFR confirm that as long as it's medically necessary, like it's a covered benefit, as determined by the prescribing provider, and it's prescribed in accordance with accepted standards of care, then insurers must cover it. Conversely, insurers may deny or limit coverage in the situation where a prescribing provider has deemed it medically necessary, but the insurer finds that based on its medical and clinical review policies that it's not in accordance with the assessment standards of care because both conditions have not been met. While we understand that the language is from House Bill 2002, we are concerned about the broad latitude that are given to providers in this provision, which could result in coverage of services well outside of what was contemplated in House Bill 2002. And procedures that are not safe based on valid clinical evidence provided. So we requested that the rules include language adding the ability for insurance to rely on their medical and clinical review policies to determine if it meets the appropriate standards of care chosen by the prescribing provider. Another area that we highlighted in our written comments, it's also concerning network adequacy. We really urge the DFR to address or let us know what the DFR considers an unreasonable delay, because that was not addressed in the bulletin. We find that it's really essential that the DFR include in the rules the factors that will be used to consider what will be unreasonable delay. As you know, providers, especially specialty providers, are currently experiencing higher than normal wait times for appointments, and a lack of providers for specific treatments in the state should not be the basis for an unreasonable delay finding. And then lastly, too, we requested that maybe a provision be added requiring the enrollee to contact the insurer prior to seeking care out of state, so that the insurer can work with the enrollee and assist the enrollee in finding an in-network provider, or, in the case where we can work with the provider and sign a special case agreement with the provider. There were other questions that we put in our comment letter that we would also like the DFR to address pertaining to network adequacy, but I'm not going to go through all of it here. It is in our comment letter. But we really appreciate the engagement. We also do appreciate the revisions in the second draft of the rules, but we believe there's still a few work to be done in terms of clarification needed for insurance to consistently administer this. So thanks for the opportunity to comment.
Thank you very much, Antoinette. And I want to apologize to Amy Penkin. It was my oversight that I did not refer back to the list of RAC members. So you are a RAC member, and I would like you to offer you the opportunity to follow up on Seth's comment letter, or if you want to hold that until we get through all the highlighting the written comments, we can do that too. So just want to put that out there.
Thank you, Lisa. It was unclear to me if this was a time for discussion on those comments received, or if we are looking at discussion more at the time of reviewing the draft rules. So I can defer either way. I just wasn't sure where we were in process right now.
Well, I'll ask my colleague Brooke what her preference is, just for the flow of things. So we have about 3 more to get through. So
Brooke Hall, policy analyst for the division. We will be going through all of the changes in the draft rule right after we review the comments. And so if you have comments about the changes in the draft rule, I would ask for you to hold those until we get into that discussion, so that we can allow others to join that discussion as well.
Okay, thank you.
Okay, I will defer until we're talking about the draft rules. I was previously just wanting to underscore a comment that Seth had made for some clarity, but I can wait until we are in the point of discussing the revised rules.
Okay, well, I appreciate that. Thank you. So next, let's go to Jonathan with Cascade AIDS Project. If you would like to highlight anything in your written comments that you submitted to the division, now would be the time.
Yes. Sorry, I had it in front of me and then.
No worries.
Yes, Cascade AIDS Project submitted public comments. The highlights are that we supported the language in the original draft defining accepted standards of care as WPATH standards of care version 8. We proposed revising the draft language to better ensure that providers reviewing adverse benefit determinations have appropriate experience. A lot of that was incorporated into the current draft that's before us, but as Seth highlighted, I think there's could still be additional revisions to ensure that appropriate experience. And then we proposed some language modeled off of existing network adequacy rules to better ensure network adequacy for gender affirming treatment. That language wasn't taken up, although there was a lot of changes to that section of the rule that I know we'll get into. That's about it for us.
Thank you, Jonathan. And also for the record, I've introduced myself before, but I did not do it at the beginning. I'm Lisa Emerson. I'm a senior policy advisor for DFR, DCBS. Next, let's go to Pacific Source. I don't know if Rick Blackwell was able to join us today or not.
I'm here, Lisa. Thank you.
Oh, awesome. Thank you.
Just try to keep it brief. Okay. My comments in general just noted that we want to be careful copying statutory text into rules so that we don't, if we miss a word or change a word, that we don't have conflicts between the two sources of law, which I don't think anyone really wants delays in interpretation. And so just trying to keep the rules to the minimums necessary. As far as definitions, I think, we supported WPATH in the HERC process. And so, supportive of it here. We did ask that maybe some accommodation for standards that are at least in accordance with or based on WPATH might be included in the rule, just so that, as the evidence changes and things, advance in care, that the rules capture that advancement as well, which is something that's been done in the mental health parity rules that DCBS wrote in 2022. Was one of these Zoom meetings anyway. I think still trying to figure out the origin of calling out cost sharing in section 2 of the draft, that denial or limiting coverage can include imposing additional cost sharing. Just want to make sure I think I understand where this is coming from, but I want to make sure that we talk about that more fully here. In network adequacy, it seems like, let's see here. I had the same comment as Antoinette, that understanding what unreasonable delay means in this context is probably the most, impactful thing we could do in this rulemaking without copying network adequacy rules or statutes into this rule. And then I missed a sentence of network adequacy. So we just believe something. Anyway, that's kind of the balance of what I wrote. Happy to take questions.
Thank you. Yeah, we can, let's go ahead and jump to Chris Coughlin with Oregon Consumer Justice. And then once they're concluded, then we can open up for comments about the written comment letters. So Chris, go ahead.
Thank you. Yeah, Chris Coughlin, she, her pronouns. I'm with Oregon Consumer Justice. And just will add to what Seth and Jonathan shared, looking at WPATH version 8 as the accepted standard of care, really in our written comments asked for more kind of clarity and detail around the appropriate experience for reviewers, and then some language about how to get at that issue of network adequacy that protects consumers. So look forward to the additional conversation today.
Thank you, Chris. So does anybody from the RAC membership or DFR staff have any questions about any of these comments? Okay, I see a hand up. Aaron, go ahead, please.
Great, thank you. We did not, Erin Waters, she, her pronouns, Black and Beyond the Binary Collective. We did not submit public written comment, but are definitely part of conversations and agreement around WPATH 8 as the standard, as a medical, being used as a medical standard. And trying to identify some opportunities to really discuss what network adequacy is going to look like in the end. But yeah, just significant support around trying to ensure WPATH 8 is an accepted standard of care, with some questions around how things are used in conjunction or superseding it. So.
Thank you, Aaron. Any other RAC members have any questions or comments about the written comments we've discussed so far? Okay. Let's see if I see their hand up. I see Tasha Sizemore. Tasha, with the division.
Hi. Yeah, hi everybody. This is Tasha Sizemore from the Oregon Division of Financial Regulation. I am the Life and Health Program Manager for the division, and I do have a follow-up question that is sort of in line with the previous comment. I would just be interested to know what those other standards are proposed to be, just for my own personal awareness. And it's not necessarily something we would have to discuss at this point, but it would be interesting to know that, to better understand what insurers are thinking about in terms of like other relevant standards that may be in use. So thank you.
Thank you, Tasha. I think we will be getting into that definitely when we get to that part of the draft rule review. So I saw a hand go up and then it went down. So seeing no other, it was Seth. Do you still have a question, Seth?
I think it pertains to that, so I'll wait for that part of the discussion. Thanks.
All righty, thank you. So let's go ahead and I think I can pass the baton to Brooke and we can bring up a copy of the latest draft rule and begin that discussion.
Great. Thank you, Lisa, and thank you for bringing up the rule, Karen. Again, my name is Brooke Hall. I'm a senior policy analyst with the division, and I use she, her pronouns. So I'm just going to review the changes that were made to the draft rule. I'll go through each of the changes that were made, read the section in full, and then allow any opportunity for discussion about the changes. Any questions before we get started? All right. I'm hearing none. So moving to the first change that was made to section 1A. And in that section, we just added the correct statutory reference to the definition of gender-affirming treatment. The next change is in section 1B. We removed the language which stated "and without limitation," adding language indicating that the statements of recommendation in the WPATH 8 are what we're looking at in terms of accepted standards of care. We corrected the WPATH name because it wasn't fully spelled out in the original rule. Removed language indicating that the WPATH will be incorporated to the rule as an exhibit. Likely, instead of doing that, we will put it on a web page. And then we also added language to allow other evidence-based sources to be used in conjunction with the WPATH 8, but not as a substitution for the WPATH 8. Now, again, this was my attempt to allow for flexibility with the understanding that our interpretation is that the WPATH 8 is the accepted standard of care at a minimum. It's the floor, and that is, according to our interpretation, was the legislative intent here. So any comments, questions, feedback on that section? I didn't see the order that hands were raised, so I'm just going to call them out as I see them now. And if anybody else has comments or questions on this part, please raise your hand. So I'll start with Seth.
Thank you. I just wanted to speak to the first component, the statements of recommendation. Curious why we are only utilizing that component or allowing that to just be used at a minimum. The statements, when you look at WPATH 8, are summary sentences that are kind of followed by the why for providers and the background, full context to understand the practice and the scope. And so would see some challenge there if that is the minimum accepted standard. Rather, we've changed the language to at a minimum rather than what was there previously. So just kind of curious about that change and concerned about the impact that that would have to not use the full text of why an evidence reviewed statement was provided.
I'm sure I can speak to that. So this was a recommendation that was made by a RAC member, and my understanding, and again, I am not an expert on WPATH, so my understanding is that the statements of recommendation are really where the crux of the guidelines are. If that is not the case, I would love to hear your thoughts on that or other RAC members' thoughts on that as well.
Sure, I can follow up. They're basically summary sentences. It's a single bolded sentence that says, we recommend a professional use language in settings that upholds principles of safety, dignity, and respect. To me, that's not very thorough. What is thorough is the paragraph that follows with the cited studies, evidence review, proven mental health improvements based on certain procedures, and followed studies on how patients are interacted with by providers. The full provided recommendation is the paragraph below in conjunction with the summary sentence. So to only use a broad sentence might not do our patients the just need that they have for their providers' care.
Thank you, Seth. And I believe it, and correct me if I'm wrong, but I believe it was Antoinette who suggested that change. So Antoinette, do you have anything to add on that if it was you who suggested the change? If not, I apologize.
Yes, it was me that suggested the change because, again, based on what was provided in the last RAC, the discussion, it is really supposed to be guidelines, and it's just statement of recommendations that can be adopted, because those are the other evidence-based recommendations that WPATH is putting forward as recommendations. That's why.
Thank you.
This is Amy Penkin, she, her pronouns, program manager for the Transgender Health Program at OHSU. And I'm a licensed clinical social worker and certified with WPATH and the standards of care through the Global Education Institute. And I have pretty deep knowledge of the standards of care. And just so everyone is aware, this is a document separated into multiple chapters, 18 chapters. Each chapter begins with a summary statement of recommendations with text that follows that goes into the detail of the statement, including the evidence base that supports that statement. That's what's in each of the 18 chapters. Now, subsequent to the chapters, there are 5 appendices that go into detail, including a glossary. It gives an explanation of the methodology behind the creation of the standards of care. It goes into some specific guidelines around gender-affirming hormone therapy, as well as another appendix around the summary criteria for hormonal and surgical treatments. And then I think what became the focus of discussion at the last meeting was Appendix E, which was a listing of gender-affirming surgical procedures, with a particular clause on that page that describes the list of procedures and an acknowledgement and recognition that between iterations of the standards of care, there may be advances in technology and growing understanding of the needs of gender diverse and gender expansive people. So I'm not sure if, and I would love to hear back from Antoinette, if the recommendation was simply to exclude the appendices or the body of the text of the recommendations that give the evidence and the more nuanced understanding of the statement of recommendation. So that I would want to be sure that we have the true intent of the standards of care that have more nuances to broaden understanding of just a single sentence statement of a recommendation. And then and just to finish my thought in this section around other evidence-based guidelines and recommendations, I think what's confusing to me around this change of language is that there aren't other evidence-based guidelines I'm aware of right now that comprehensively address gender-affirming medical and surgical and mental health treatments. And if the thought is to use another guideline in conjunction with, but not substitute for, this language here sets up a condition that 2 guidelines can be in conflict with one another and gives no guidance about how one would proceed. And it doesn't make sense that we would be introducing the possibility of another guideline that has not been established or vetted or defined as evidence-based. So it's confusing to me that we would introduce that in this rule. And I'll pause here.
Thank you, Amy. And I want to give Antoinette an opportunity to respond. So go ahead, Antoinette.
Oh, great. And on behalf of me speaking, I actually have my clinician here on the call, and I would like to give her the opportunity to speak to it. Hopefully she is on this call.
Yep, I'm here.
Great. So Ruth, please introduce yourself.
Yeah, this is Ruth Barrett. I'm with Regions. And so this need for, or this addition or recommendation to add the statements of recommendation did come from those discussions around, discussing some of the nuances in the appendices and whether those were meant to apply. And I understand the statement that all of the rest of the guideline supports those statements of recommendation, but those are the statements that they're putting forward as the recommendation. And so I think, in terms of what do we need to follow, that's my understanding of what WPASing should be followed, whereas the information in the rest of the document can be used to support those. And I don't think that saying that we have to follow the statements of recommendation takes away from the supporting documents, but clarifies what actually needs to be followed when the rest is more descriptive, if that makes sense.
Thank you, Antoinette, and thank you, Ruth. I am gonna move on to the next raised hand that I see, and that is Jonathan. Jonathan, do you want to go ahead and?
Yeah, thank you. I agree with Seth and Amy that limiting the definition of accepted standards of care to just the statements of recommendation just doesn't really make sense. It excludes a ton of integral content from the standards of care, including not just like Seth and Amy mentioned, the explanatory statements, but important other appendices related to the methodology, introductory chapters that provide a lot of contextual information. It's like going through this document that's intended to be taken as a whole and highlighting very select pieces of text. And then to also second what Amy said about the sentence that's been added about other evidence-based guidelines, I think it introduces a tremendous amount of uncertainty for both carriers and consumers around what the standards of care actually are, because as Amy noted, there are no other comprehensive evidence-based guidelines. So it's kind of it's looking to standards of care that haven't been put forward. The term with recognized expertise in gender-affirming healthcare just offers a ton of discretion that won't, it offers a ton of discretion. I'll leave it there. And then I just don't understand how, if a standard of care emerged and it was in conflict with WPATH, how this sentence here would provide guidance in that situation, how you would use it in conjunction with, but not as a substitute for if it offered conflicting guidance. So we would advocate for that sentence to be, but for that language to be removed.
Thank you, Jonathan. And I do, I want to open it up for opportunity for those on the RAC who did provide comments indicating that they would like flexibility to kind of answer Tasha's earlier question and the question put forth by Jonathan, which is, are there other evidence-based sources or guidelines out there? And if so, if you believe that there are, what specifically are they?
Brooke, you have a few hands up. I don't know if you see the order. They might want to talk about that. I don't know.
Let's see. Let's start with Merlene. Thank you, Lisa.
Hi, good afternoon. My name is Merlene Converse. I am with Kaiser Permanente, and I wanted to speak in support of the comments made by Antoinette and Ruth Barrett about the statements of recommendation. Kaiser Permanente aligns with, I'm not going to repeat what Ruth said because I think she stated it well about the appendices and just whether the statements of recommendation is the right phrase to use here. We agree that we need clarity about if something is mentioned in passing, but is not currently a recommended course of treatment. we want to be aware of that. There are some services that are not commonly provided in the United States today. And so having language about statements of recommendation does help carriers know the breadth of what they are expected to cover under this requirement. So I do think the language is helpful. Thank you.
Thank you, Marlene. Now I see Chris, go ahead.
Thank you. I just want to speak from the consumer perspective about the importance of comprehensive understanding of what's being covered. And, we supported the WPATH 8 being the standard of care and do have some of the same concerns that you've already heard about limiting that to short sentences that don't have the full range of what that includes. And so are concerned about some of that, the additional language, that statement of recommendation language. And also want to flag, and Brooke, you already asked about like, what are these other evidence-based guidelines? So at this point, given the current landscape, feel that WPATH 8 is what, is there, and feel, seems like the piece that the rule should be built around, and and not opening it up to other yet unknown unless there's, some more clarity around that. But my understanding is, as Amy and others have said, we're not sure what those might be. So look forward to the continuing conversation.
Thank you, Chris. And Aaron, I see your hand up as well.
Yes. Aaron Waters, she, her pronouns, program director at Black and Beyond the Binary Collective. I am in kind of a similar place. Like I originally brought up the question of how things work in conjunction, because WPATH is approved by so many medical organizations. We've got AMA, American Nursing Association, College of Physicians. This is the accepted standard by a lot of different organizations. And so the ability to produce something different is something I would really be interested in, because I don't know what exists, and I do look. And just combining a bunch of studies is not the same as a body of medical professionals who've been doing this for a decade consistently. And so, yeah, and then of course, questions around, if it sounds like if we reduce it to just those sentences, then it does discard certain things that might be important. And it is understandable that we don't want to, people don't want to commit to coverages that they aren't even aware of yet. I think there's a way for us to talk about that. The community understands that. Same around when we get to network adequacy, the community understands our limitations. What we want to make sure of is that those limitations aren't going to keep them from getting other medically necessary care that we have available right now.
Thank you, Aaron. Let's see, and I just saw Rick, your hand go up. Go ahead.
Oh, yeah, I guess Chris had already commented. We can always open these rules up later if things change, right? I mean, rulemaking is easier to accomplish than the statute, so than changing a statute. So, I mean, certainly getting something in place for implementation would be great, and then revisiting it as circumstances change. Certainly on the table, right?
Yes, we open up rules all the time when we have to make minor and major changes, and it can be done if needed. I'm not seeing any other hands, so again, I want to ask the question, if there are any RAC members who believe that there are other evidence-based guidelines out there that should be used as a standard of care, can you please speak up and let me know what those are? I have done some research in this area, and like others have said, I have not found any specific standards of care for gender-affirming treatment other than the WPATH 8. What I have found is there are several organizations who have issued policy statements in relation to gender-affirming treatment and gender-affirming care. Those include the American Association of Pediatrics, the American Academy of Child and Adolescent Psychiatry, the Endocrine Society, the American Association, oh, sorry. There is another one, I didn't write it down though. So my question is, are those what others are considering evidence-based guidelines and sources, or are there other ones out there that we do not know of? And Lisa, I see your hand up, go ahead.
Yeah, Brooke, I just wanted to flag that Sally Kreenick, a nurse practitioner, did put something in the chat, and perhaps that can be discussed in the public comment period. It depends on when you would want to discuss that, but it's referring to a Harvard clinical guidance document. Just wanted to flag that for you.
Thank you, I appreciate that. I think I will, there is another statement that I will likely read during the public comment section, so I will read that during the public comment as well. And I see Everett, I see your hand up. Go ahead.
Yes, thank you. Hi all, my name is Everett Redente, he, they pronouns. I am a social worker and community advocate here. I work in insurance, but I'm not representing insurance today. I just want to flag that within the WPATH standards of care, the model that Fenway Health uses, which is part of what Sally referred to, is listed as a source, a citation within the WPATH standards of care. So that is also a part of this document too. And if I understand the concerns around using statements of recommendation, or the purpose of using statements of recommendation, I do believe it does a disservice not only to the insurer, but the consumer as well, in not providing the full context of WPATH in its totality. The statements of recommendation are clear, but they are also broad and vague. So the information, the science and data and research behind everything is really in the bulk of the document, and that you're not going to have that within the 1 sentence or 2 sentence lines that are under each statement of recommendation section. So again, to echo what folks have already shared, I do think it's essential to include WPATH SOC 8 in its totality and not leaving it to vague statements of recommendation within each of the 18 chapters. And similarly, like the other evidence-based guidelines, there is nothing that currently exists that is this comprehensive, that applies to all the fields of care and professions. And again, this is an internationally used document. There's a lot of time, effort, science, data, research that's gone into it. And WPATH is constantly challenged due to my understanding of transphobia, constantly challenged in a way that other standards of care are not, simply because it is in support of gender-affirming treatment for transgender people. So I don't want anti-trans bias to influence the reliability and credibility of this document and all of the time and effort and science and data that has gone into it from around the world over the past 10 years.
Thank you, Everett. All right, I'm going to move us along in the changes here, but again, if anyone on the RAC has information about other accepted standards of care, please provide that in your comment letters. Great, so Karen, if you scroll down, the next change was in number 3, and this language was added to provide clarity that utilization review practices are allowed to verify adherence to accepted standards of care. This was a request in one of the comment letters. I'll read this in full and then provide opportunity for any comments, suggestions, feedback. So currently it says carriers may use utilization review practices to verify adherence to the accepted standards of care described in subsection 2B, provided that such practices are consistent with the requirements of this rule and all other applicable provisions of Oregon law. Utilization review practices shall be implemented in a manner that does not unreasonably limit or delay access to care. So the first hand I see is Rick. Go ahead, Rick.
Thank you, Rick Blackwell again, Pacific Source. I was trying to figure out what this adds that House Bill 2517 from 21 doesn't address. There's already a lot of utilization management standards that we apply in all circumstances, not just gender affirming care. And so I just trying to figure out, like, what does this add that's already not covered by the statutes?
So are you saying you don't think it's necessary, Rick?
Yes, I don't believe it's necessary, but I could be wrong. So I'm happy to be proven wrong, but I just don't, from my understanding of the insurance code, thinks this is needed.
Thank you, Rick. And again, I hate to put you on the spot, Antoinette, but I think this might have come from one of your comment letters as again. And so do you have anything to add or say about this section in particular? And it may not have been written in a way to capture what you were saying. If that's the case, please let me know.
Yeah, I think we commented on the fact that although the coverage will be determined by the provider to be medically necessary and prescribed by the provider, based on also the accepted standards of care, we want to make sure that we are also able to use our utilization review criteria to ensure that it is in accordance with the accepted standards of care. So it's more like a collaboration and not only the relying only on the prescribing provider accepted standards of care. So that was the reason why we recommended that the DFR amend the routes to include something to that effect.
Thank you, Antoinette. And Tasha, I see your hand. Go ahead.
Yeah, just a quick follow-up question on that. What types of utilization review would be used in this situation? If the law says that it defers to the provider, what kind of utilization review would an insurer be conducting?
Antoinette, would you like to speak to that?
Yes, actually, I would like to defer to my expert, my SME on that. Ruth Barrett, please.
Right. So I think that the question is whether we can deny it in disagreement with the provider, right? That's really the question that we were left with after reading the previous draft, and that this was meant to address, is that if a provider said it is, within standards of care, but we disagree with that, is that allowable to disagree? And so I think that's where this suggestion came from.
So there's just to clarify, there's no particular utilization review tool that is being considered in this particular case. It is just to open up a path to ask the provider for more information, more supporting documentation. How would this be used to kind of disagree with the provider?
Right. So we discussed in previous meetings how there are some procedures that may not be, supported by evidence to be safe. And that doesn't mean that providers don't submit those. And when they submit those, they are saying they are standard of care. And so if we are following our standard of care, following WPATH and the evidence, we just want to be able to say it's not just the provider said, it's standard of care, and that's the end of the story, right?
Okay.
So I would just like to clarify that the language in the rule doesn't allow a carrier to make a decision that would be opposite of what a physical or behavioral health care provider prescribes. The language is very clear that if it is prescribed as medically necessary, as determined by a physical or behavioral health care provider, and is prescribed in accordance with the accepted standards of care, then it must be covered. And this language does nothing to exclude that. So just want to make that clear.
I'm sorry, I didn't mean to disagree with that. It's just that second part, the standards of care, who was determining the standards of care, just emphasizing that piece.
So any other comments on this section? Okay. Moving along, the next change that was made was just updating numbering here, and number 3 was changed to number 4. And if we move down, the next change is to letter V, which we added the word procedure. And there was a request by a RAC member to define the word procedure. What do others on the RAC think of that? Do we need to add a definition of procedure to rule? And I believe, Rick, you're the one who made that suggestion, and I see your hand up, so go right ahead.
Yeah, what did I did request a definition of procedure. I mean, I think we're talking about surgical operations here and not drugs or other treatment, but I want to make sure, like, that's because that's what I think that's what the statute said, I recall, isn't it? I'm looking at 2002 real quick. I also just want to make sure that all of section 4 like aligns exactly as the statute is written. If we're going to copy it in, it's got to be exactly the same, because, oh yeah, here we go. So what would this be? Subparagraph E in the statute, so page 9 of the enrolled bill, calls for a combination of gender affirming treatment procedures. So we'd have to add that anyway, just to be consistent with the statute. I think procedures has a plain and ordinary meaning. I just want to make sure that everyone understands that that's also the case.
Yeah, and I just have a clarifying question here, because my understanding is that not everything that is included on that list below is considered a surgical procedure. So for instance, my understanding, and I could be wrong, is hair electrolysis is not a surgical procedure. And so I don't think all of the items that are enumerated here are considered surgical. Do others have thoughts about that? Go ahead, Seth.
Yeah, I would echo that. Laser hair removal, electrolysis. I wouldn't necessarily say that those are, surgical, and I think there are other components of the provisions of HB 2002 that cover, hormones are covered in here, and so I think there are components of this that are not surgical in HB 2002 in the law language itself.
May I ask a clarifying question, Seth?
Yeah, go ahead.
Are there other, because this language in this section is exclusive to cosmetic services, and the exclusion of a service that is considered medically necessary. So a carrier cannot exclude a medically necessary procedure as a cosmetic procedure. So are there other items that would be considered under this, that should be considered under this list?
Under this list, when you're looking at typical denials, when we look at a combination of treatment, that is typically like when you're seeing tissue construction work being done on a gender affirming care chest, where you're removing or maybe doing a double mastectomy, but the masculinization of the chest for the individual, that potential code for the liposuction, et cetera, is not, or the fat grafting is not covered, where other components of it might be, or where you're having a phalloplasty penile stage 1 covered, but you're seeing the implant being denied because it's an implant and it's a product. And so the purpose of not saying just combination of procedures, we're also talking about the actual product of the implant being denied, that allows for potential, phalloplasty and erection purposes as part of the full stage of that procedure. I might be saying that incorrectly, so I encourage our health system partners like Amy Penkin and the surgical team to kind of elaborate on that if I haven't spoken it correctly. But to me, this is more than just surgery. It's also including products and devices included in surgery.
Thank you, Seth. And I see, Jonathan, your hand is up. Do you want to go ahead? You're on mute, Jonathan.
Thank you. I just wanted to clarify that I guess I don't see that particular subsection as that important because this entire section is additive to the base of the statute. All of this language was included to provide extra layers of protection around what advocates see as being the most commonly denied procedures. But the inclusion or exclusion of any of these, I through V, wouldn't change the fact that if they're medically necessary and prescribed in accordance with standards of care, they cannot be denied. So just wanting to give that context of if the phrase any combination of gender affirming treatment or any combination of gender affirming treatment procedures, the inclusion or exclusion of that wouldn't change what carriers are responsible for doing. I'll also just say that I don't, as one lay person, ultimately, I don't think of procedures as surgery. For example, I would think of electrolysis as a procedure. It's not a surgical procedure, but it's something that's kind of performed on a body. So just offering that.
Thank you, Jonathan. And next I see Everett. Go ahead.
This may not be necessary at this point, but also just coming from somebody who's very familiar with coding and insurance, medical tattooing would fall under this, which is usually done after surgery to change appearance and pigment, or for areola repigmentation. So that's one, and also speech therapy for voice dysphoria is something that would also fall under here. So again, adding more examples to procedures, not necessarily being only surgical in nature.
Thank you. And next I see Amy.
I would just echo threads of what Seth and Jonathan and Everett all suggested, that in the context of the law, gender affirming treatment is an inclusive term to reference procedures, service, drug, devices, or products. So I don't think the word procedures here is additive or necessary.
Thank you, Amy. Any other comments? Oh, Rick, go right ahead.
It is completely necessary because it's in the statute. So we can't be, enlarging the statute through this rulemaking process. So I mean, either we copy this fully, and that includes what the statute says, or we don't. And that's, an amplification or interpretation of the statute. So I hate to be a stickler on this, but if we are going to use statutory text, it's got to be the whole thing.
Thanks, Rick.
And this is Antoinette from Cambia. I totally agree 100%.
Thank you, Antoinette. Any other comments, feedback? Okay, I'm going to move us on to the next change, which is in section 5. And this language was added to clarify who can review an adverse benefit determination. So first, we added A, which says the adverse benefit determination is, oh, I'm sorry, let me just read the whole thing. Prior to issuing an adverse benefit determination that denies or limits access to gender-affirming treatment, a carrier offering a health benefit plan shall ensure that A, the adverse benefit determination is reviewed by a physical or behavioral health care provider, that is language that is in the statute, and B, the reviewing provider meets the following criteria. This was language that was added. Holds a valid license issued by a health professional regulatory board, practices within the scope of practice as defined by their licensing board, has experience utilizing standards of care that include but are not limited to the World Professional Association for Transgender Health's Standards of Care for the Health of Transgender and Gender Diverse People, version 8, WPATH 8, and has completed a training program focused on gender equality and inclusivity. So comments feedback about this section? Go ahead, Jonathan.
Yeah, two comments about this section. The first is I feel like there might have been a miscommunication about the training. Cascade AIDS project, and I think other commenters suggested that a threshold for training for the reviewing provider could be the GEI certification offered by WPATH, which I think stands for Global Education Institute. And we saw gender equality and inclusivity GEI appear here in the language, so I'm not sure if that got lost in translation. I don't think that completing a training program focused on gender equality and inclusivity is sufficient, or certainly not comparable to the Global Education Institute training offered by WPATH. Our other concern about this section is we had proposed requiring that the reviewing provider demonstrate experience related to the treatment being reviewed. And that recommendation came from the fact that gender-affirming treatment spans all these different fields of care. It even spans physical and behavioral health care. You can see in this language reviewed by a physical or behavioral health care provider. So not making that specification has us concerned that a provider who does not practice in that field of care could be reviewing. An example is there are real world examples of psychiatrists reviewing surgery claims. That's kind of on its face not appropriate. So we would prefer to see that the reviewing provider be required to demonstrate experience related to the treatment being reviewed.
So just a clarifying question for your recommendation for letter 4, would it be to add that the training program would need to be administered or come from WPATH? Or is there a specific program that WPATH provides that we need to put here in the rule? Is that your suggestion?
That's my suggestion, and that suggestion is, and I would defer to Amy, who is GEI certified, and others, that they're similar to standards of care. Unfortunately, there aren't a whole lot of options of really rigorous training, rigorous kind of broadly recognized training programs. So I don't mean to be overly specific in offering that suggestion, but that is sort of the option that we have.
Thank you. I see Amy, you have your hand up, so I'll let you respond when it comes your turn. But next we have Rick. Go ahead, Rick.
Thank you, Rick Blackwell, Pacific Source again. I think this one might be as well unnecessary, and I only raise it as in the process of going through the appeals route. Independent review organizations under current law have to have clinicians that are in the same or similar specialty as the provider who prescribed the treatment. So that's ORS 743B 256. That was put in place as part of House Bill 2517 a couple of years ago. So my assumption is that, like, if someone was going through the process of an appeal route, eventually they would reach a provider with experience in gender-affirming care. My internal experience here at Pacific Source has been usually end up in an appeals process consulting with someone with the experience as well to make good decisions. So I just think that this might be at best belts and suspenders. I think the training program too, I wanted to raise whether or not, since this isn't really in the statute, but kind of related, if this would be reflected in the fiscal impact statement that goes out then as to, are we going to incur costs for having these training programs available, and how much would that be? Or is that something that would be folded into contracts with IROs, down the road? So like, I think this is already covered by the insurance code and probably unnecessary.
Thank you, Rick. May I ask another clarifying question? Are you saying the whole section is unnecessary, or just adding a section or a statement which says that the reviewing provider needs to have experience in the type of procedure that is being reviewed?
I think the statute already gives us that answer, and we don't need to repeat it in rule. I suppose you could reference back to the relevant sections of the insurance code just so that people know where to look, if that's maybe an acceptable way to draft it, but I think it's unnecessary.
Thank you, Rick. And Amy, go ahead.
I would just underscore in this section B of the reviewing provider meeting the following criteria. I would underscore with number 4 that completed, I would say, a foundations course with WPATH Standards of Care Global Education Institute. The foundations course is designed to give an introduction to the WPATH Standards of Care. So anyone who is reviewing patients' care, recognizing that we're following the evidence-based practice of WPATH Standards of Care. The Global Education Institute Foundations course would be, at minimum, the necessary training to apply an interpretation of the standards of care in practice.
Thank you, Amy. And I did write that down, but I would just ask that you also provide that in a written comment so I make sure that I have your suggestion accurate.
I will enter that in the chat.
Thank you. And next I see Scott.
Hi, good afternoon. My name's Scott White. I'm the Director of Regulatory Affairs for Moda Health. And I just wanted to agree with the issues that Jonathan rose, because as soon as this came out and I'm reviewing it with our internal teams, all of the questions that Jonathan brought up were what they asked, where at first we felt it was very clear in the House bill who could review these claims. And now there were questions, well, what kind of training? We have an internal training about, and I don't think that was the intent here. That would not be a focused enough training for gender equality and inclusivity, that what's being referred to here, as well as utilizing standards seems, and I'll let the medical professionals, speak to this, but utilizing standards of care, well, many doctors do that, and they might have even been familiar with WPATH, but that doesn't mean they should be reviewing for these services. And basically kind of going back to ensuring that uniform approach for our members across carriers in the state of Oregon, and also just from a market conduct standpoint, from an issuer, that we're very clear on who should be reviewing these claims, and we don't have this language that could cause confusion and cause issues during, well, for one, more importantly for our members, but secondly, during a market conduct audit from an issuer. Thank you.
Thank you, Scott. And next I see Seth. Go right ahead, Seth.
Thank you. Yeah, I just wanted to note the who can review the component of just echo affirming Amy's comment around making some clarity here. And I also think one of the pieces to look at is the clarity for the consumer around the description of experience. I think I've started to see some real life examples of reviewers simply stating somebody experienced in gender affirming, getting a statement of someone experienced in gender affirming care has reviewed this, and it's not, and something we're going to cover. Just in Washington, when they passed a similar Gender Affirming Treatment Act, there were much more stringent guidelines for the reviewer, and I attached that in my public comment that I submitted last time that folks can see, that really looks at requiring there to be transparency as to what their at least title is to the patient, or at least the insurer and the carrier, some of their experience listed, because I'm concerned about, as an advocate, seeing a vague statement of someone experienced in gender affirming care reviewed this, and their name without understanding what the context of their experience was, to make sure that there's accountability there for who the reviewer is, that aligns with these protocols. So I also would actually encourage there be a look at Washington's protocol and rulemaking that was much more clear around the reviewer's certification and the transparency to the public about what that certification is in alignment with what trainings they have received in gender-affirming care. It's really robust and there's a lot there. I'm wondering if folks have taken a look at the Washington rulemaking on the exact mirrored bill that was passed in 2021-22 up there.
Thank you, Seth. I have looked at the Washington rulemaking. I can't speak to whether everyone on the RAC has looked at the Washington rulemaking, but I'd be happy to provide it as a material for the next rulemaking. For the next RAC, I mean. And Everett, I see your hand. Go ahead.
Yeah, I also just want to echo the importance of defining this section and specifically regarding training. From my own anecdotal experience, I've already seen denials come in with a claim from insurance saying that somebody with experience in providing this care has reviewed and determined that adverse termination of benefits, so they're not going to cover or only cover a portion of whatever the requested procedure was. I've seen that used, and the citation that was used wasn't WPATH, which also like is its own issue. So it made me question, how can we have folks saying they have experience and citing sources that don't include WPATH standards of care as saying that as electrolysis in particular was denied and said that electrolysis is always cosmetic. So there are some concerns there on multiple levels, but the fact that this person was contracted out to work with the UM department and in insurance said that this contractor said that they have folks on staff who have this experience, which again wasn't defined. So we don't have that definition of what experience means. And if you have experience, why aren't you referencing WPATH? So I think the importance of adding WPATH specific training, because I do trainings all the time, but all the trainings done on gender and more nuanced concepts within gender-affirming treatment, they're not all the same. And if we're going to apply the standards of care, WPATH standards of care, to be the standard of care, then we need to have folks who are trained and understand what the standards of care are actually saying.
Thank you, Everett. Are there any other questions, comments, concerns about the language in this section? Go ahead, Rick.
Thank you. So this is something that we grapple with in a number of specialties. I'm trying to figure out what would the division do if it had a complaint about any sort of care where it's been reviewed by someone where the credentials of the person reviewing it were at question. Because I feel like there's probably other types of specialties where this could come up as well, and I think it'd probably be good to understand how these would be resolved.
Tasha, I hate to put you on the spot, but if you're still on the call, do you want to respond to that? You might not be on the call anymore, Rick, so I will take down your question and provide a response at the next RAC meeting.
Okay, thank you.
All right, moving on to the next change. This is in C. We just, again, are clarifying that this subsection means subsection 5. And then the last major change to the rule is the language around network adequacy. Specific language regarding network adequacy was added to the rule, and I'll read that in full, and then we can have a conversation about the language. So 6, carriers offering health benefit plans shall make reasonable efforts to contract with an adequate number of providers to facilitate access to gender-affirming treatment without unreasonable delay. 7, if a carrier can demonstrate due diligence in attempting to contract without success with an adequate number of providers for gender-affirming treatments due to provider scarcity, the carrier will not be found in violation of network adequacy standards, provided that A, the carrier ensures coverage for out-of-network gender-affirming treatment services without additional cost sharing to the enrollee beyond what would be incurred for in-network services, And B, the carrier communicates transparently with enrollees about expected wait times for gender-affirming treatment services and provides assistance in finding the nearest available provider. So anybody have thoughts about this section? I would like to just point out that there has, on this call as well as in comments, there has been numerous requests for the division to define unreasonable delay. And I would like those on the call who are RAC members to just provide some guidance around what you believe that should look like. Because again, there's not a definition of unreasonable delay in current federal or state statute. And so this would be a new definition. Antoinette, I see you're first. Go ahead.
Yeah, so this is Antoinette again from Canby Health. At least we were one of the insurers that did requests for the DFR to clarify what unreasonable delay is, because many of these services are not considered urgent or emergent in nature. So some of the wait times for them are to be expected due to the current state of, the provider healthcare landscape. So again, it would be helpful for the DFR to include something along the lines that, as long as there's not an unreasonable delay for an in-network provider for these services, members should be required to see an in-network provider and not go out of network without the carrier knowing or approving the out-of-network care. And I plan to provide written comments, and that's something I would include as well. And this is also tied, this is also tied to the out-of-network portion of the rule.
Thank you, Antoinette. And I apologize, I was just told there's 10 minutes left in the meeting. I thought we went until 3, but perhaps we only go until 1:30, or 2:30, is that correct, Erin?
Correct.
Okay.
That's what it shows on my calendar, at least.
All right. Thank you, Antoinette, and thank you, Lisa, for pointing that out, because I would have just kept going. So with that in mind, I'm going to allow Rick to provide a comment, and then we're going to move on to the public comment and next steps section of the agenda. And I will note that we will have a more robust discussion on this network adequacy section at the next RAC, since we didn't get to it today. So Rick, go ahead.
And I'll follow up in written comment, but two things. The rules that are mirrored here in section 7 relate to when a carrier elects to use a factor-based standard for network adequacy, and not when someone is using a nationally recognized standard like NCQA. So I want to make sure that understand that that's kind of an elective approach, and this is becoming a prescriptive approach across the board. And there's no real network adequacy changes in the statute other than you follow what's in law and the rules that are interpreting that law. So I think we should revise 7. I think we also need to figure out what providing assistance means. That makes sense to me with my Medicaid hat, in the care management context, but that's not necessarily how commercial insurance works. And so if we're asked to do more and have to plan and have the resources, that'll have to be reflected in the fiscal impact statement.
Thank you, Rick. All right, so again, we'll have a more robust discussion on this section at the next RAC meeting, and also about any additional changes that we make to the rule. But now I would like to provide the opportunity for public comments. I did see one person, Paul Turdal, who requested to speak during the public comment section. If there is anyone else who would like to provide comment, please put your name in the chat or raise your hand. And Paul, just in the interest of time, I do have a statement to read, so if you could limit your comment to 3 minutes, that would be great. Go right ahead.
Great. Can you hear me okay?
I can.
Great, thank you very much. So my name is Paul Turdal. For the past decade, I've worked as a volunteer health consumer advocate for individuals with autism and other disabilities. In recent years, there's been a surge in comorbidity between autism and gender dysphoria for reasons that remain unclear. I have a long-standing interest in ensuring that health consumers can access medically necessary evidence-based care that they need to thrive. At the same time, when I worked with Senator Bates on autism health insurance issues a decade ago, he taught me the importance of ensuring that the right patients get the right care at the right time, and also of ensuring the importance of access to quality evidence-based medicine. I'm very concerned that many of the recommendations in WPATH 8 go well beyond the generally accepted standard of care, especially for children and adolescents with comorbid conditions such as autism. A year ago, the Health Evidence Review Commission initiated an evidence-based review of gender-affirming treatment, including WPATH 8. The draft report, which has not been published, found serious gaps in the quality and strength of evidence. For instance, quote, "We did not find any SRs with extractable data on gender-affirming medical interventions among adolescents and youth," unquote. The report also noted that many of the studies that do show benefit were based on very narrow, highly motivated patient populations with much stricter selection criteria than called for under WPATH SOC 8. For instance, quote, "Many of the European carriers require extensive, e.g. months to years, of evaluation and counseling prior to receipt of services. The outcome of studies from clinics with wait lists or prolonged evaluation procedures may reflect a healthier, more motivated, or more socially supported population which could be at lower risk of both procedural and psychosocial complications," unquote. In a meeting with HERC's director and medical director last week, they acknowledged that the evidence in their draft report does not meet HERC's customary standards for evidence-based medicine. I have encouraged HERC to complete its work and publish expert guidance on the standard of care, which could be helpful for this process. When the legislature passed HB 2002 last year, there was a strong emphasis on the idea that medical decisions should be made by medical doctors, not legislatures or courts. They shouldn't really be made by financial regulators without medical training either. But defining a formal standard of care in your rules would do exactly that. It would compel medical directors, who are licensed physicians, to make medical decisions following proprietary HERC or proprietary WPATH criteria, which does not necessarily meet Oregon standards for evidence-based medicine. No one on this Rules Advisory Committee is licensed to practice medicine in the state of Oregon. You shouldn't define WPATH or any proprietary guideline as the official standard of care. Instead, you should just refer to the statutory definition of standard of care from ORS 677.265 and let medical professionals do their work. If there are disagreements, they can be resolved through external medical review. By defining a standard of care, the division risks being named as a co-defendant in any medical malpractice litigation, since physicians will point to the administrative rules you are writing as a defense. Director Stolfi could find himself testifying in court about his medical credentials and why he felt it appropriate as a non-physician to define the standard of care for medical service. One other thing quickly, during the legislative process, Director Stolfi sent a letter to Speaker Rayfield expressing the division's view that detransition procedures would be included in the definition of gender-affirming treatment. He further pledged to address this during rulemaking. I'm disappointed to see that it hasn't been included in your draft yet. Consistent with Director Stolfi's commitment, please add a provision of the rule clarifying that detransition procedures are included, and please work with detransitioners to ensure that this aspect of the rules is complete. Thank you.
Thank you, Paul. And Sally, I see your hand up.
Hi, I'm sorry, I don't know if this was already addressed. I needed to leave to see a patient, but I'd mentioned the Harvard guidelines in the chat, just for an example of where the WPATH guidelines and the Harvard guidelines might diverge for estrogen patches, the dosing on estrogen patches. Again, just as an example, WPATH lists 0.02 is, or 0.2 is the, whereas Fenway or Harvard lists for 0.4 milligrams is the highest dose. So for that, for a patient who I feel that higher dose is appropriate for, if only WPATH guidelines are accepted, would that be an issue for a patient getting the adequate dose for their specific circumstances? Thank you so much.
Thank you, Sally. And I did receive a public comment, a written public comment from Camille Kiefel. In the interest of time, I'm not going to read it today, but I will provide it to all the RAC members via email. So if there are no other public comments, I'm going to move us along to the next steps portion. So next steps. So our next RAC meeting is currently scheduled for April 9th from 1 to 3. We really want to allow adequate time for everyone to review the draft rule and provide feedback on the rule. So we will likely move that date back to allow for that. So with that in mind, please provide any feedback on the draft rule by the end of business on April 5th. And we will look at later dates for the RAC and provide that information as soon as possible. And Lisa, anything you want to add as far as next steps?
Well, the only thing I'll add is, because we kind of are tossing a date around, we're thinking about April 25th, but we're not firm on that, but we are pushing the date back for the next RAC. Thank you, everybody.
Thank you, Lisa. Antoinette, go ahead.
Oh, me? Did you call?
Yeah, go ahead.
Okay. So if we provide comments on this second version of the draft rules, should we expect another version to come out before the next April 25th RAC meeting? Okay.
Yes, I mean, that is part of the reason for pushing the RAC back, is not only to provide you with ample opportunity to review the rule and provide feedback, but also to allow Lisa and I the time necessary to review all the comments received and to make any changes that are necessary to the rule. And if there are changes that are made to the rule, we will provide that before the next RAC meeting, hopefully allowing you the weekend to review it like we did for this as well.
Even for the portions we have yet to review, we should probably expect changes if comments are submitted.
If comments are submitted, yes.
Okay.
We will likely make
that
changes.
persuades you. Okay, thank you.
Any other comments, questions before we end? All right. Well, thank you, everyone. I really want to thank you for the really robust conversation that we had today. It was very helpful for both Lisa and I really encourage you to please provide any written comments on some of the suggestions that were made today, so that Lisa and I can ensure that we're reflecting those accurately in any changes that we make. So thank you and have a great day.
Thank you.
Thank you. Bye,
Thank
everybody.
you.
Thanks.